Good morning to one and all. I think there are participants from different parts of the world, so I should say good morning, good afternoon, good evening to one and all who's attending this session. And this is a free session. This is sorry, there's an echo from this. I hope that I can continue, and if there is any technical errors, I'm sorry for that. And my name is Dr. Varun, one of the specialist surgeon in UK, and I'm running. I'm just teaching for my fellow colleagues from different parts of the world to know what's happening in UK, what is the protocols, what how they do things, how they go about with the management of these patients, and this should be helpful for both MRCS and FRCS examinations. And any doubts, anything you can put up in the chat, or it's this class is live in YouTube and also in Facebook. And you can get a reminder from Eventbrite. And there's no, it's not chargeable, it's free of charge. And usually it will be run on every Saturday, 7 o'clock. In the 7 o'clock in UK time. And let's go to the session. And today's topic will be as easiest topic to start with. And I know that it's a bread and butter in UK and many parts of the world, especially in Western world. So the topic for today is gallstone, and everyone should know about. As a general surgeon, everyone will be knowing about gallstone and the acute cholecystitis and all these benign pathology and malignant pathology. But what I'm going to deal here is how the UK protocol runs, how the diagnosis and management of the gallstones and gallbladder pathology are tackled in UK will be dealt in depth. And also things, if there is any doubt, we'll discuss for that for 10 to 15 minutes in the at the end of the session. And anything you can raise, even if it is a silly question, I'm happy to help you, happy to discuss with you, and we'll take it forward from there. So basic anatomy, and everyone knows bile is the key substance which digests the fat, and it's a catabolic product of heme. Hemoglobin, after it gets disintegrated into heme and globin, heme becomes bilirubin, which gets conjugated in the liver, and it's secreted into the common hepatic duct and into the duodenum for fat digestion. Little bit of anatomy here. So the liver has got as units of central lobules, and these lobules has hepatic veins or venules in the middle, and there are hepatocytes which secretes the bilirubin, which is collected in the biliary canaliculi, and these biliary canaliculi gets collected as a bile duct in the portal tract, and the collection of bile duct becomes the common hepatic duct and the cystic duct. Cystic ducts connects to this common bile duct, which gets drained to the second part of the duodenum. So as such, the biliary tree, there are right and left hepatic duct, which drains the concerning liver, and the bile is stored temporarily in the gallbladder, which is drained into the common bile duct, and the common bile duct drains into the second part of the duodenum. So let's go to a little bit of physiology and so bile secretion and its regulation. So bile is usually secreted when the stomach gets fatty food. The stomach and duodenum senses the fat, and the mucosal lining senses the fat, and it secretes cholecystokinin. This cholecystokinin enters via blood and causes contraction of the gallbladder, and this contraction of the gallbladder is also reinforced by the vagal stimulus from dorsal vagal complex. Together, it contracts the gallbladder, and there is a relaxation of the sphincter of Oddi, which helps the gallbladder content or the bile to enter into the duodenum. And after it enters into the duodenum, the fat gets emulsified. It's like a kind of uh, process where the fat gets digested and it gets absorbed for its nutrients. So this is the basic regulation of the bile secretion. So composition of the bile, majority of the bile has got water, and there are bile acids, bile pigments, and cholesterol, inorganic salts, fatty acids, phosphatidylcholine, fat, and alkaline phosphatase at some times. And there's a bit of difference. This might not be known to many of the people. There's a bit of difference between the hepatic duct bile and the bile which is there in gallbladder. So the hepatic duct bile, or the bile which is there in the hepatic duct, is slightly different from the gallbladder bile in its constituents. The hepatic duct bile has got 2 to 4 percentage of solid components, and gallbladder bile is bit concentrated. It is 10 to 12%, and there are 10 to 20 millimoles of bile acids in hepatic duct bile, and gallbladder bile it has got 50 to 200 millimoles, and the pH of the gallbladder bile is slightly acidic than the hepatic duct bile. In other words, the hepatic duct bile is thinner and the gallbladder bile is thicker comparatively. There's no gross difference, but still the, the gallbladder bile is slightly concentrated. So how the bile acids, what are bile acids and bile pigments? I think this is a basic physiology which has to be known to all the MRCS people who's appearing for MRCS. The bile acids are produced from cholesterol, which is the primary bile acids are cholic acid and chenodeoxycholic acid, and these are helpful in formation of the bile salts. And the secondary bile acids are formed in the intestine from the primary bile acids. The secondary bile acids are deoxycholic acid and lithocholic acid. The conversion is done by the intestinal bacteria. So this is the most common thing which happens. This is enterohepatic circulation. Whatever the bile, bilirubin, which so sorry, this is how what is the color of the stool color and the urine color is determined by the bilirubin. The bilirubin, which is present in the bile, when it enters into the intestine, it becomes urobilinogen and it is converted into stercobilin and stercobilinogen. The stercobilinogen is converted into stercobilin, which gives the brown color to the feces, and the urobilinogen is absorbed into the systemic circulation, which is converted to urobilin in the kidney to give the yellow color to the urine. So this is the reason why our stools are brown and the urine is yellow. And there are, I'll explain what's the reason. How can a patient have a pale stool, and how can a patient have dark colored urine in an obstructive jaundice in future slides. So intrahepatic circulation, 95% of the bile acids are converted to bile salts and are reabsorbed into the portal system, and it enters into the liver, and this is called as enterohepatic circulation. There is a passive absorption. I can say this is there's a passive absorption of the bile acids all over the length of the small intestine, and there is an active transport of biles, bile bile acids from in the terminal ileum into the portal circulation, and this portal circulation help, takes the bile acids or bile salts into the liver. This is called as enterohepatic circulation, and only 5% bile salts are excreted in the feces. I repeat, it's only 5% of the bile salts are excreted in the feces, and things are rest of the things are reabsorbed into the um, portal system, delivered to the liver, and it goes as a cycle. This is called as enterohepatic circulation. So what is the reason why I'm stressing these things, like the physiology of bilirubin getting converted into urobilinogen and stercobilin? This helps in the clinical diagnosis of obstructive jaundice, and also this helps in the reason why there is a high colored urine in an obstructive jaundice or in a hemolytic jaundice. And the enterohepatic circulation is a key factor in determination of gallstone formation when we do a ileal resection or small bowel resection, or right hemicolectomies with ileal resection, terminal ileal resection. So most of the 95% of the bile salts are reabsorbed in the terminal ileum as an active transport. So when we resect the terminal ileum, as a post-operative complication, we have to expect a gallstone or biliary pathology, where there is a chances of gallstones. And this is the clinical significance of knowing the enterohepatic circulation, and clinical significance of learning about the bilirubin uh, pathology, bilirubin physiology. So what are the risk factors in formation of gallstones? And everyone knows about the next slide. I think this is the easiest way to remember what are the risk factors, like female, fair in the sense like Western or Caucasians, fatty women, fertile women, those who are on oral contraceptives or post pregnancies, and those who are in 40s, or this is called as female, fat, fertile 40s. This is the whole concept of remembering what are the risk factors of gallstones. In addition to this, I would like to explain this thing as a risk factor as well. And the most common gallstones are extremely common in Western world, and it's in the Europe as well, in the Americans and Australians. And it is it's common in the advancing age group, but most of the time in the advanced age group people, it's asymptomatic. And the patients, female gender, and patients, persons who are on oral contraceptives, pregnancies, obesity, and insulin resistance, rapid weight reduction. This is an important key factor. Nowadays, there's an increasing trend in gallstone formation in patients, those who are undergoing bariatric procedures like sleeve, Roux-en-Y procedures, and there's a rapid reduction in weight in those people. So there are precautionary prophylactic cholecystectomies done in Roux-en-Y procedures for some patients. Those who are interested, there's something called as biliary dyskinesia or biliary gallbladder stasis, where there is a decreased motility of the gallbladders. There's no cause for this. It happens. Sometimes it happens in the diabetic. This is called as biliary dyskinesia, and the most important investigation which we do is a HIDA scan uh, to assess the motility of the gallbladder, which helps in diagnosing the reason for the dyspepsia and gallstone. And there are inborn disorders of bile acid metabolism, dyslipidemia syndromes. Coming down to the most common thing, see, it's not most common, sorry, 10% of the stones are pigment stones. The pigment stones can either be a black stone or a brown stone. The brown stones are infective stones. The brown stones are formed because of uh, infection due to E. coli and other kind of bacteria, enteric bacteria, and the pigment stones are due to hemolytic anemias, and the pigment stones of 10 constitutes 10% of the gallstones, most commonly in Asian population and rest of the world apart from the Western world. And it's more common in hemolytic anemias like sickle cell anemia and hereditary spherocytosis. And it is, as I said, the biliary infection can lead to brown stones. And as a other thing is like gastrointestinal diseases like ileal disease, Crohn's disease. I said about the terminal aerial and enterohepatic circulation, which helps, which is the reason, one of the reasons for gallstone formation in Crohn's. The terminal ileum, if it gets if it gets involved, there's a disturbance, and there's a disturbance in reabsorption of the bile salts, which can lead on to the gallstone formation, ileal resection, bypass, cystic fibrosis. Again, if there is any ileal pathology. So these are the risk factors for gallstone, and I could not see any other risk factors apart from these. And these are the things which will be concentrated in the exam point of view, and other uh, smaller risk factors are not considered in this topic. So I dealt about this slide, and this is the easiest mnemonics to remember uh, the risk factors of gallstones. These are the types of gallstones. You could see the shape and size and the color of the gallstones. And cholesterol stones are slightly bigger. Usually it's more than 1.5 like, sorry, it's like more than 5 mm or 6 mm. It's slightly larger than the pigment stones usually, and the pigment stones are usually slightly smaller in terms of comparison of the sides. And the cholesterol stones usually are yellow in color. As everyone knows, fat is yellow and gets crystallized and forms yellow stones. And pigment stones, as it is from the increased bilirubin, uh, it it gets the color of the bilirubin, and it's usually dark brown or green, dark green in color, and mixed stones. And these are the types of stones, gallstones. And what is the rationale? How the gallstone formation happens? And there is a uh, there is a difference in the proportion of these the proportion of these three things. There's a difference in the proportion of these cholesterol, phosphatidylcholine or lecithin, and bile salts. When there is a change in the proportion of these constituents, when the cholesterol size increases, cholesterol amount of cholesterol increases in the bile, and when there is a decrease in the phosphatidylcholine, when there is a change in the alteration in the bile salts, there is a chances of crystallization of the bile, and initially there is a micelle formation and there is a crystallization which forms the bile gallstones. So in other words, when there is an increased cholesterol in the bile, the infection or micelle formation is the trigger, which is from the mucus, and there's a crystallization around the mucus, which forms the gallstone. So this is a repeat slide. I don't think I think I dealt with this. So cholesterol stones are caused by imbalanced bile composition and improper gallbladder emptying, and that it's usually yellowish green in color. Pigment stones are caused by conditions that produce too much of bilirubin. It's dark brown or black in color. And again, I think this is dealt. Okay, so coming on to the symptoms of the gallbladder, gallstones. So what is the symptom of the? Usually it is it is called as biliary colic. There are different symptoms. I'm going to explain you what are the differences in the symptoms. Biliary, what is biliary colic? What is a, what is it called as acute cholecystitis, and how we are going to differentiate all these things. Biliary colic, it's a pain which starts from the visceral peritoneum due to the distension of the gallbladder. So biliary colic is a visceral pain caused by the distension of the gallbladder, and it is the pain which rises from the visceral peritoneum. So the stretch of the gallbladder causes the pain, and the gallbladder it's felt at the dermatome of T9. So it starts the right upper quadrant, goes as a band of pain on all towards the dermatome 9, and it lasts not more than 30 minutes, and it settles by itself. So this is called as biliary colic. So the location of the pain will be epigastric or right upper quadrant. It lasts more than 30 minutes. Yeah, it's more than 30 minutes. Radiation, it goes round through the back. It's like a band like. The patient will have a classical history of band like pain around the right upper quadrant, at the level of right upper quadrant, going back towards back. And the severity, the patient will say he or she has never experienced such a kind of pain. The most important thing is the patients may say it triggered after a fatty meal, especially like cheeseburgers and any kind of cheesy, greasy foods. So these are the classical feature of biliary colic, and the patient will not be the patient who has biliary colic doesn't mean the patient will have a gallstone. So the biliary colic is due to the pain, which is because of the visceral pain, which is because of the distension of the gallbladder. So this is to insist that. So if there is a patient with biliary colic or just biliary dyspepsia, in other terms, the patient has got bloating sensation, right upper quadrant pain. We do an ultrasound scan, there is no gallstones, and there's a sludge is nothing but a thickened form of bile where there's no gallstones. So in this scenario, when the surgeon tries to operate, the patient might not be getting relieved of pain. The patient may have pain even the gallbladder is removed. So this is because the bile gets into the pylorus as a reflex mechanism, and this dyspepsia will continue till we treat the dyspepsia, till we make sure that it treat the acids and all these things rather than removing the gallbladder. And 10 to 30% of the patients who has cholecystectomy with a documented gallstone, still they fail to relieve biliary pain. So this could be the reason why the reason could be because of the bile which is getting into the stomach, that causes the biliary dyspepsia. So there are 4 episodes of, so any patient who's asymptomatic uh, gallstones, or 1 episode of gallstone in a year has got 38 to 50% chances of getting another episode in the next year. And there are 30% of the patients who had gallstones or biliary colic will never have any further symptoms. For example, a patient who comes with a gallbladder biliary colic, and we do an ultrasound to pick up a gallstone, and that patient might not have, if the patient gets conservatively treated and the patient gets discharged, this patient might not have symptom. 30% of these kind of patients might not have further symptoms in their lifetime. Likewise, as I said, you one patient who gets the symptom on the first year, there's a 38 to 50% chance of patients to have recurrent symptoms on further episodes. notes for the years. So what is acute cholecystitis and biliary colic? I think by this time I explained you what is biliary colic to some extent, and acute cholecystitis is, as everyone knows, that this is inflammation of gallbladder, and it's not because of distension of the gallbladder alone. There is an inflammation of gallbladder as well. So this is the basic difference between biliary colic and acute cholecystitis. And biliary colic and in acute cholecystitis, there will be associated symptoms like fever, rise in white cells, where C-reactive protein will be raised, and there will be associated other signs of inflammation. But in biliary colic, there won't be any signs of inflammation, like the white cells will be normal. Though we have ultrasound proven gallstones, the white cells will be normal. Your C-reactive protein or inflammatory markers will be normal. Your liver functions test will be normal. So almost in biliary colic, the blood parameters will be normal. However, in acute cholecystitis, uh, the inflammatory markers will be at least slightly raised to say it is acute cholecystitis, and the ultrasound will show that it will show a pericholecystic fluid collection. So it means there's an inflammation of the gallbladder wall. So in that's the difference between the biliary colic and the acute cholecystitis, and usually it lasts more than 30 minutes, and it lasts 2 hours, and there is an irritation of the parietal peritoneum due to the inflammation of the gallbladder wall. So this causes the Murphy sign. Murphy sign is nothing but catching of breath when the patient takes deep breath in, and you feel for the gallbladder in the right upper quadrant. The patient catches for breath, and there is a tenderness and rebound tenderness in the right upper quadrant, which is a classical feature of acute cholecystitis. In biliary colic, there is a slight differentiation. There's a distension of the gallbladder, and there's no inflammation of the um, gallbladder wall. So these are the complications of gallstones. So first, it will go one by one, 1, 2, 3, 4, 5, 6, 7, and the first complication of gallbladder is any gallstones can obstruct the cystic duct, causing distension of the gallbladder wall, and can cause biliary colic or biliary pain. And this stone can get impacted, cause inflammation of the gallbladder wall, causing acute cholecystitis. This acute cholecystitis can lead on to, when it is not treated properly, it can lead on to emphysematous gallbladder, gallbladder perforation, gangrene of the gallbladder, and so on. And the third is the stone can get impacted at the level of the cystic duct, and it can produce Mersey's syndrome. I'll put up another simple slide to know what exactly is Mersey's syndrome. And the stone can get impacted at the level of the junction or the confluence between this common bile duct and the pancreatic duct, or at the outlet of the common bile duct into the duodenum, causing gallstone pancreatitis. So gallstone pancreatitis is another entity which will deal in a separate session or at some point. And there's another thing called as cholecystoenteric fistula for a gallstone ileus, or for a gallstone ileus or Bowerett syndrome. It's nothing but there's a compression of the gallstone over the duodenum and erosion of the duodenum, causing gallstone ileus. It's called as Bowerett syndrome. And there is a long-standing cholelithiasis resulting in gallbladder carcinoma. There is a 3% incidence of gallbladder carcinoma patients, those who have gallstones in a long term, has an incidence of 3% of gallbladder carcinoma. It's nothing but, so in other words, it goes as a porcelain gallbladder, and it comes as a porcelain gallbladder, and these are more prone for gallbladder carcinoma. And there is an impaction. So everyone knows that there is an impaction of stone in Hartmann's pouch, resulting in gallbladder distension, mucosal. So mucosal is nothing but when there is an obstruction of gallstone, when there is the outlet obstruction of gallbladder, it means the gallstone obstructs the cystic duct, and there is no more bile enters into the duodenum, or no bile enters into the gallbladder. So the function of temporary storage of bile in the gallbladder is stopped by the stone which is obstructing the cystic duct. So in that scenario, the mucus secretion of the gallbladder stays there and causes mucocele. So no more. So in mucocele, the color of the fluid in the mucocele will not be green. In other words, the mucocele is like a whitish mucousy secretion in the gallbladder, which doesn't have any bile biliary um, uh, color. And if it is not infected, it will be staying just like that. And if there is an infected mucocele, if it is getting infected with like Clostridium, there can be some gas forming organisms which can produce gas inside the gallbladder as well. So these are the complications of gallstones as such. And sometimes we can see gallstones which is obstructing, which a huge gallstone which passes into the duodenum, moves way long into the terminal ileum, causing gallstone ileus, terminal ileum, gallstone ileus. So these can be picked up by the ultrasound, it can be picked up by a CT scan, or it can be picked up by um, X-ray if the stones are opaque. So everyone knows about, I think, things most of them know that 90% of the gallstones are radiolucent and 10% of the gallstones are radio opaque. So this is a Merz's syndrome, and this is just a simple form of Merz's syndrome, simple classification of Merz's syndrome. There's other classification with like fistula, and 4 types of fistula when there is a complete connection. I'm not going to deal with that classification. Here in this type 1 Merz's classification, it has an impactor stone causing external compression of the common hepatic duct, and the type 2 is the external compression or cholecysto choledochal fistula, where the gallbladder impacts and forms a fistula into a common bile duct. So type 1 is compression over the common hepatic duct. Type 2 is compression and fistula formation in the common bile duct. So as I said, emphysematous cholecystitis can be because of E. coli, Clostridium, anaerobic streptococcus, gallstone ileus, which has already done, and gastric outlet obstruction due to impaction of a gallstone in the duodenum is called as Moretz syndrome, and gallbladder rupture can happen in 1% of the patient, which can cause biliary peritonitis, which can lead on to biliary sepsis, peritonitis and sepsis. So next comes the common bile duct stones. And common bile duct stones. So I think this for the first picture says about the common bile duct stones. The ERCP, the tube is the ERCP, the dark shadow is the ERCP telescope, which is there in the duodenum, and the dye is in the fluoroscopic dye is inserted, and you can see plenty of filling defects in the common bile duct, and this is the filling defects which is seen. These are the defects which are seen in the common bile duct. It's called as or the common bile duct stones. And this is a picture where you can see a choledoscope, and this is the papilla where the cystic duct, and these are the common bile duct stones. And 8 to 16% of patients with symptomatic gallbladder stones will have simultaneous common bile duct stones. So whenever we come across any patient who has gallstones, we have to make sure that there is no stone in the common bile duct. Without analyzing the common bile duct, the gallstone the gallstone assessment of any patient with gallstone is not complete. So it doesn't mean that the patient only has stone in the gallbladder alone. There is an 8 to 16% chances of patients having simultaneously there can be chances of having common bile duct stones. And the formation of common bile duct stones can be either primary or secondary. Secondary is the, as I said, secondary is the stones from the gallbladder are pushed into the common bile duct, and that can be the secondary stones. There are chances of formation of stones as such primarily in the common bile duct, straight away in the common bile duct. That can be because of infection. Mostly it is uh, brown pigment stones, which are fragile, soft and fragile stones in the common bile duct. And the investigations to assess the common bile duct stones, MRCP, is the most commonest investigation. We can do ERCP if we are very clear. And the most initial screening test is ultrasound and the liver function test. When there is a deranged direct bilirubin, you we come to a conclusion that there's an obstruction. Sometimes there will be slight variation in the slight increase in the direct bilirubin. In such scenario, there can be a partial obstruction of the common bile duct. In all scenarios, there won't be a complete obstruction of the common bile duct. So when this common bile duct is completely obstructed, we will have a full-blown picture of direct bilirubin which is raised. But when there is a partial obstruction, when there is a movement of bile into the duodenum still there, we can't expect a full-blown direct raise in here bilirubin. So in other words, don't expect direct bilirubin to be always raised when there is an obstruction. It doesn't mean when there is a slight raise in direct bilirubin, doesn't mean that there is no obstruction in the common bile duct, or there's no stone in the common bile duct. So make sure that we have both the things analyzed. So the next the symptoms of the common bile duct stones are jaundice, fever, right up quadrant pain, and this is always called as Charcot-Strides, and it happens. This is called as cholangitis, and the causes are E. coli, Klebsiella, Enterococcus, and gram-positive bacteria like Enterococcus species. And treatment start with antibiotic as early as possible, because cholangitis is a serious condition. Like cephalosporin or ciprofloxacin, we use most of the time we use ciprofloxacin IV or oral. It has same bioavailability, so either oral or IV is going to be should have the same bioavailability. And renal pentads is nothing but when there is a Charcot triad, which is associated with hypotension and altered sensorium. Uh, it's called as renal. Severe form of cholangitis called as renal pentads. And this is a broad tabular column to assess what exactly is happening with the liver function test and what is its significance. So when there is an increased urobilinogen in the urine, think about hemolytic jaundice. When there is an increased conjugated bilirubin, increased alkaline phosphatase with bile salts and bile pigments in the liver test, it suggests it's a obstructive jaundice. Always ALP is increased. Most of the time, ALP is increased when there is a biliary tree pathology, and ALT and AST is increased when there is a hepatocellular pathology. And when the functions of the liver are getting down, think about prothrombin coagulation profile and the proteins. And so I think this gives a rough idea about how to analyze the liver function test. So what are intrahepatic stones or primary bile duct stones? As I said you already, intrahepatic stones. Sometimes we can see stones in the common hepatic duct or right or left hepatic duct, which is slightly rare, but still there are few cases which has been reported. Intrahepatic stones are more commonly due to infective stones, and there is a when there is a cholangitis of the hepatic ducts, there is a chance of stone formation in the hepatic ducts, right? Left hepatic ducts and still further above the common hepatic ducts. So these are the primary bile duct stones or intrahepatic stones. Management lies the same. It's CBD exploration and flush with the saline and the open take of these stones. And how are we going to manage the gallstones? So if there is a gallstone, asymptomatic gallstone, so we do a ultrasound, CT scan, and we pick up one single stone, which is incidental finding. Usually, as I said, there's a less chance of further episode or acute episode. Even even if we don't treat, there's no much of difference. And as I said, the patient who develops symptoms from asymptomatic group 2 to 3 years. That's second of response. Uh, so patients who has asymptomatic stones, there is a 2 to 3% of patients with asymptomatic stones can develop symptoms every year, and approximately 10% can develop symptom in 5 years. So altogether, if there are 100 patients with asymptomatic stones, 2 to 3% can develop in symptoms in first year, and 10% in next 5 years. So it's very meager. So out of 5 years, only 10 patients with asymptomatic stones can develop symptoms. So symptomatic management, when the patient has got acute cholecystitis with CBD stones or without CBD stones, and when there is a multiple small tiny stones which produces gallstone pancreatitis. So all these patients will be helpful with laparoscopic cholecystectomy. And a brief, I'll just explain you. I think I don't want to get into the procedural part. If anyone needs procedural part, please comment on the YouTube or here. Let me do a separate session on laparoscopic cholecystectomy. Cholecystectomy is do's and don'ts and all the things. I think plenty of people know about laparoscopic cholecystectomy. And medical management and dissolving the stone, it's a rubbish idea. If anyone thinks about management of gallstones with medicines or some kind of dissolving stones, this has already been tried in the past by plenty of medical professionals, and it has never worked out for any patient. It has landed up in plenty of complications rather than uh, treating the cause. So never ever think of medical management of gallstone. It's not possible at all. So this is the guy who did the first laparoscopic surgery. He's from Germany, Erich Muhi. He did his first laparoscopic cholecystectomy in 12th of September 1985. So laparoscopic cholecystectomy is not a age-old procedure, it's a recent procedure. He used his rectoscope and all these things. These are the instruments which he used initial days to do a laparoscopic cholecystectomy. So there are other ways of doing cholecystectomies, like single incision laparoscopic cholecystectomy, where they use only single port around the umbilicus and do a cholecystectomy, and something called as natural orifice transluminal endoscopic surgery, or nodes wherein they remove the gallbladder either through oral route or the vaginal route. So these things are not in use, like not in common use, because compared to the laparoscopic cholecystectomy, it doesn't have much more advantage, so it's not that useful. And intraoperative bile duct imaging and prevention of bile duct injury. So this is most important thing in nowadays. Now the present practice of present surgical practice. So what are the things which can be used intraoperatively to avoid bile duct injury? One of the most commonest complication of laparoscopic cholecystectomy is bile duct injury. Before the laparoscopic era, when they did the open surgery, open cholecystectomy, they were not able to find any bile duct injury. But in the advent of laparoscopic cholecystectomy, there is a raise of 30% raise of common bile duct injury. So what are the things which are done to prevent bile duct injury? In UK, there is a commonly used thing is intraoperative cholangiogram. If there is a thought about bile duct injury, perioperatively we use intraoperative cholangiogram, intraoperative choledocoscope to check is there any stones, intraoperative cholangiogram to check is there any bile duct injury. And there is a high the things are coming up like laparoscopic ultrasound, laparoscopic ultrasound, wherein you can Google it, YouTube it. There is a port with there's a laparoscopic instrument with an end tip with a probe. It is actually more sensitive than intraoperative cholangiogram and ICG. ICG is nothing but indocyanine green, which we administer 15 minutes prior to the procedure, which delineates the, it gets secreted in the liver and bile, it enters into the gallbladder. So that can be visualized, but most commonly used is intraoperative cholangiogram, rarely used is lap ultrasound, ultrasonogram. Other things which can help in avoiding the gallbladder, common bile duct injury is or Rubius sulcus. There is a small sulcus which is in the which is that in the segment. I can say it's segment 5. This segment 5 sulcus in the segment 5 will be helpful in the dissection. In other words, this dissection uh, uh, when there is a dissection just anterior to the rubeus sulcus, we avoid plenty of damages to the hepatic artery, common bile duct, and hepatic duct, and all those things. So try to keep your dissection anterior to the rubeus sulcus and never go posterior to the rubeus sulcus. Once if you come across a rubeus sulcus, come across trying to dissect uh, away from the posterior to the rubeus sulcus, we are in the danger zone. And there are 3 techniques which can help again to avoid common bile duct injury. The most commonest technique which is used is critical view of safety. And this critical view of safety, I think everyone knows. There are only there after your dissection there should be only 2 structures which is entering the gallbladder. One is the cystic duct, the other one is the cystic artery. So when you dissect these 2 structures, and when you are clear about these 2 structures, and we can clip the cystic duct artery. So this is called as critical view of safety. And there's other technique is called as flag technique. So try to move your gallbladder Hartmann's pouch as a flag, and this is called as flag technique. And if it is completely mobile on both the sides, use your left hand to move the uh, Hartmann's pouch as a Hartmann's pouch, right and left. If it is freely mobile, it means we have completely dissected the cystic duct and artery, and this is not common bile duct for sure. If you could move the Hartmann's pouch or any structure which is which you hold on your left hand uh, freely, then it's not definite. It is not definitely a common bile duct. So I'm not sure about what is infundibular technique, but I'll look into it. So this is common bile duct injuries, risk factors. So the danger. So how like this is. So everyone says the common bile duct injury is not. It's because of the most common chances of common bile duct injuries because of dangerous anatomy. Of course, this is not because of dangerous surgery. The common bile duct injuries are happening. There are 84% chances of common bile duct injuries because of dangerous surgery, and dangerous pathology and dangerous anatomy is just less than 10%, 7 and 9 and 7 consecutively. And so So the other thing is the timing of the so this is called the critical view of safety. You can see there are only two structures which is entering the gallbladder. One is the cystic duct, the other one is the cystic artery. So these are the two structures. When you are sure that these are the two structures which is entering into the gallbladder, we can straight away clip the cystic duct and clip the cystic artery as a first thing and cut this cystic duct as the second thing. So CBD stones, how are we going to manage CBD stones? There are three ways we manage these CBD stones. Nowadays, the present era, the present uh, uh, protocol or the way how we manage common bile duct stone is, if there is a distal stone, most of the time it can be extracted by an ERCP. So this is the ERCP, the telescope. This is the telescope wherein the dye is injected into the common bile duct. You can see a filling defect here in the common bile duct and do a papillotomy at 11 o'clock position and troll basket or troll extract the stone. Most of the time these stones are extracted in ERCP. At times the stone can be impacted. In that scenario, you use a lithotripsy or spyglass cholangioscopy with contact lithotripsy. In developed world, it's usually things a bit possible. But if there is no scope for ERCP and lithotripsy, the other option is the CBD exploration. And nowadays, CBD exploration. Third option is the balloon extraction. You can see the ERCP, there's a balloon which is put in and they extract it. So this is called as a balloon extraction or balloon probe. So open versus laparoscopic bile duct exploration. So there is an increasing trend in laparoscopic bile duct exploration rather than open bile duct exploration because doesn't make much difference, and using T-tube for common bile duct exploration has completely gone out of way. And intraoperative intraoperative. So if there is a, okay, how to analyze, how to, I'll give us consolidated slide at last in next few slides. So better to go for a laparoscopic bile duct exploration if you are technically skilled rather than going for open bile duct exploration because it has got less morbidity, uh, less uh, less pain and more easy patient recovery. And regarding intraoperative common bile duct stones, even again, when you're doing laparoscopic cholecystectomy, try to avoid squeezing the stone into the common bile duct, which can cause gastropancreatitis after the laparoscopic cholecystectomy. Make sure that your stones are in the gallbladder before you remove the gallbladder out during the procedure. So this is the consolidated picture which I wanted to say. Any symptomatic gallstone disease, do the basic investigation to proceed with the management of gallstone disease is liver function test and ultrasound abdomen. The liver function test is normal. Ultrasound abdomen shows no dilatation of the common bile duct. Common bile duct, the diameter of the common bile duct is normal or 7 centimeter, not maximum of 8 or 1 centimeter, not more than 1 centimeter. Do normal LFTs, there is a very less risk of common bile duct stones. Go for a laparoscopic cholecystectomy. And if there is a normal liver function test with dilated bile duct, so make sure that your ultrasound they mention about the common bile duct dilatation. If the common bile duct is slightly dilated, there's a lower risk of common bile duct stones. And if there is an abnormal LFT, again, there's a lower risk of common bile duct stones. So in that scenario, it's better to go for laparoscopic cholecystectomy with on-table cholangiogram. If there is a stone, then go for bile duct exploration. If you are competent enough, yes, you can proceed with laparoscopic bile duct exploration. Sometimes, if the ERCP is available, if you could mobilize all of the ERCP set into the theater, yes, we can go for intraoperative ERCP. And anti-grade CBD stenting. I hope that this is less commonly used. And the other one is secure cystic that I'm not sure about it. And the other thing, the most common thing is sometimes it can be helpful if you are sure that the stone is there, the distal CBD, and it is freely mobile, not impacted, then do a laparoscopic cholecystectomy, but immediate post-op within a day, it's better to do an ERCP to extract the stone in the CBD. So abnormal LFTs, you do an abnormal LFT with dilated common bile duct, it's high risk of CBD stones. You do an MRCP, make sure that there is no stone in the CBD. CBD stones can be picked. If the CBD stones can be picked up, preoperative ERCP is always advisable rather than post-operative or intraoperative ERCP. And you can go ahead with laparoscopic cholecystectomy in a day or 2 or 10 days after ERCP, but try to avoid postponing the laparoscopic cholecystectomy for more than 6 weeks. There's a chance of recurrence of CBD stones. And if there is no CBD stones, still laparoscopic cholecystectomy with on-table cholangiogram. The other way of diagnosing, yeah, like we do a MRCP, ERCP, and still if you are not able, MRCP, if you are not able to pick up any stones in the CBD, the endo ultrasound is helpful to pick up microlithiasis of common bile duct. So the microlithiasis of the common bile duct can be picked up endo ultrasound, but the specificity and sensitivity almost equal to ERCP and MRCP, but there's a slight upper limit for endoscopic ultrasound. So other common complication during a laparoscopic cholecystectomy is bile leak. This is called as anatomy of duct of Luschka. So there is a small duct which is coming from the gallbladder bed, which can start pouring bile out after the surgery. So if we think that if there is a bile leak, a bile stain after the procedure, try to put up a drain, and that settles there's no need for any kind of intervention. Usually it settles by itself. All these minor bile leak doesn't need any repeat surgery or control. It settles by itself. And if there is a major leak from the stump or injury of the common bile duct, then it has to be dealt accordingly. So any bile leak more than 500 ml on first day, if it is a pure bile, thick bile, or second or third day, it can be first day, second or third day, try to do a ERCP, do a sphincterotomy. So it decreases the pressure in the common bile duct. It decreases the pressure in the common bile duct and decreases the pressure uh, of leakage. So most of the time the flow is laminar flow. So once if this pressure in the common sphincter of OD is released, the common bile duct functions in such a way the bile gets flowed directly into the duodenum rather than spilling out into the peritoneum. Most of the time, ERCP helps more than sufficient if there is a slight biliary leak after laparoscopic cholecystectomy. Porcelain gallbladder, this is a calcified gallbladder, and previously it was thought that 68% can lead on to carcinoma of gallbladder, but recent study shows there's a 2 to 7% chances of malignancy in porcelain gallbladder. You can see a thick wall gallbladder which is calcified, and the management is laparoscopic cholecystectomy. So L-calculus cholecystitis happens in sick medical patients, chronic morbidities, and all these things. The cause is said as like microvascular occlusion of the cystic artery or the vessels which supplies the gallbladder, which causes gangrene or sometimes gangrene or acute cholecystitis of the without any stone. And there is a 50% chance of worsening symptoms, and these patients may need cholecystectomy. If the patients are fit enough to get the procedure, then or sometimes cholecystostomy will be helpful. So these are the debates which is happening: early versus delayed cholecystectomy. Nowadays, it's better to go for a early cholecystectomy rather than delayed cholecystectomy if you get trained in the uh, early cholecystectomies. So in UK, it's usually done if it is possible, if the patient is not conservatively managed in 48 hours to 48 hours, the gallbladder surgeries are done, but not always, not like things are coming up. And delayed cholecystectomy, yes, it was previously done. It has got good safety, and this is the both the ways are good. But early means it's less than 10 days, but not after 10 days. Delayed 6 weeks, not before 6 weeks. So anything which is happening between 10 days and 6 weeks has got high chances of complications like bile duct injuries, leak, injury to the bowel, and everything. So that comes to the end of this session, and there are a few questions which can be searched, and if anyone wants to answer for this. Rokitansky Ashov changes in chronic cholecystitis. What is this, and what is the name of critical view called as? What are the signs to elicit during a laparoscopic cholecystectomy apart from the critical view? There are a few other signs. If someone wants to share their comments, they can comment in the YouTube or they can comment in the chat box session. If anyone wants to, I'm opening up the mute, unmute all, like people can unmute now. I'll keep, if anyone wants to, I've made a change in the comment that if anyone wants to ask any doubts or anything, either you can post their comments, uh, or they can ask, unmute themselves and they can ask any doubts or anything. I'm happy to clarify. Flame quartz, so see, bile pigment, bile salt 90. It's bile salts. So this video will be available in YouTube, and so anything, the next session will be gallbladder malignancy, and that will be there in the next Saturday, the same time. And anyone who needs any topics, any further topics which you are of interest, can post that in the comments in YouTube, or you can email me at my email ID, and you can join the Telegram group for the updates. And there are plenty of things which is happening, and any doubts, I'm happy to clarify. Welcome, 14. Thank you. Thank you all. And I want, if anyone can help me with this, someone can. Thanks for the comments. And I would like you guys to post the comments, and if there is any need for any further topics or doubts, clarifications, any doubts about FRCS, MRCS, or anything about your career progression, you can email me to my email ID. You can email me, comment in the comment section in YouTube. So I'm happy to help you guys, and happy to, whenever time permits, I can't reply you back at the same time. I'll definitely send some the clarifications, whatever you want. Thank you for attending. Thanks for attending the session. The next session will be the same time, Saturday morning, 7 a.m. UK time, with gallbladder malignancy, which I'll deal, including the hepatic resections and all these things for gallbladder malignancy. Thank you all for attending. Once again, thank you. Bye. I'm going to stop this conversation. Thank you.